Well, good afternoon, everybody. First of all, thanks, EBART, thanks, Amelia, Mina, for this invitation. I don't know if you knew this, but in the United States, there are more people that like Pepsi than Coca or Coke. But in the rest of the world, more people like Coke than Pepsi. So please raise your hand who like more Coke than Pepsi. Okay, a lot. What about Pepsi to Coke? Not too many Americans? Okay, so yeah, it is interesting. And there are some people that like some other colas. Does anybody like other colas here? No, I don't think so. Do you know that more people prefer cold colas than warm? And some add some lemon. So if you want to survey and see if people like Coke or Pepsi or other colas, you have a really problem. So welcome to my world, my researcher world, and especially my researcher world when want to evaluate endometrial receptivity tests. So, spoiler alert, heterogeneity is a problem. We have to test Coke and Pepsi and warm and cold and lemon and young and older people. And it is not easy to say if one is better than the other one if we mix up all the information. So to make a summary about this is not easy. So I have nothing to disclose. Let's start talking about why testing endometrial receptivity tests. So sometimes we have good quality embryos or even euploid embryos, and we do transfers once and again, and patients do not get pregnant, or what we call repetitive implantation failures, which, by the way, it is not easy how to make a good definition of that. So that is why we sometimes think we have to test the endometrium. And it is also true that we try to improve our implantation rates, and somehow in the last time it was not easy, and we have steady results. So it is a moment where you start thinking, okay, maybe there is another thing that we should test. We know about embryo and endometrial synchronization, and if we want to do a precision medicine that is focused on individual patients, we have to individualize the treatment. So that is why we started thinking, not we, some started thinking about endometrial receptivity tests. Some things that we all know: progesterone induces a modification in the endometrial epithelium, the window of implantation. And there are several platforms that intend to predict when the window of implantation is open. ERA from iGenomics was the pioneer, but there are some or many other platforms testing different set of genes with different technologies. So talking about receptivity in endometrial receptivity test is talking about lots of different things. And the goal is to personalize, to diagnose, and to make a better synchronization of the endometrial factor with the embryo. So some challenges that I have already mentioned about searching for evidence here is heterogeneity. So we have different set of genes, different technologies, different populations. It was tested in some people that did it for the first time, some people that did it transferred many times, some people that did PGTA. So it is not easy to draw a single conclusion for all of them. And also we need good quality evidence, and we don't have many randomized control trials. So it is also difficult to obtain or to have high certainty of evidence. Besides, if the condition is not prevalent, there is a high frequency of false positives. And that is true for everything. So if we test this in general population, it could happen that we have a high percentage of false positives. So that is something that we should have in mind. And also, we should do it properly. And do it properly, for example, is to test progesterone before starting with luteal phase support. Otherwise, we could do this test in someone who started with high progesterone levels, and then we don't know if we are testing in the correct moment. So whenever, if you are a researcher and you want to do a study about these type of technologies, you have to control each of these single characteristics to make something that could be, that you can reproduce then in your office with your patients. So there are some people that said, put a very big title like ERA is an improving technology. I usually don't like this, not specifically if you don't have a real very strong quality evidence saying that it is an improved technology. So it is fair to talk about physiology, about models, about epidemiology. But if I want to draw conclusions, to know what to do with my patients, I need to see what is the best available evidence and proceed according to it. And then when I started with this research, I started reading what was there. And then I found a systematic review that was published in 2022. The search was finished in 2021. It included 1 randomized control trial, 2 prospective observational studies, and 8 retrospective observational studies. As you can see here, you can see the forest plot with good prognosis, poor prognosis, and perceptive, non-receptive test. But what it is there in red is the I-square. The I-square shows us how heterogeneous that population or those populations could be, at least those results are. And you can see you don't need the I-square. Usually whenever it is over 50 or 60%, it is very heterogeneous. It is very difficult to believe that this diamond is representing all this. It is like putting the head in the oven and the feet in the fridge, right? And thinking that, well, I am at 37 degrees. I am not, right? So my head will be burned. So it is very heterogeneous. Yes, pears and apples. So that is not what we want to do. When they evaluated clinical pregnancy rates, still they didn't find any difference in good prognosis, in poor prognosis patients. This diamond is there. Here they didn't find any, there was not heterogeneous, but at the same time, they mixed different types of studies. For example, this one published by Carlos Simon, it was a randomized control trial, and it was mixed up with some others that do not have the same risk of bias. And then another systematic review was published, this time published by Sarah Arian in 2023. And here we have the same problem, a very high heterogeneity, an I-square that is 83%. Again, you can see this here. So it is really difficult to believe in this number as a summary of everything. And you can see here that a randomized control trial was included, also some studies with adjusted estimates, but again, the I-square very high. So this is important to understand that it's not just a matter of a forest plot and a few single numbers that are where we obtain an average. It is also to understand which numbers are there. And then we decided to do something else with a little or not so little more information additionally, trying to evaluate this heterogeneity and see what we can say from each of the groups. So we worked with Dr. Karina Lates, Miguel Spese, and Agustin Ciaponi on this. And we performed a systematic review again with Cochrane methods. We published in Prospero the protocol. And then we searched a lot of databases just to bring all the data that was there published until October 2022. And we decided to include only comparative studies, so randomized controlled trials, and also retrospective and prospective cohorts in which there was a comparison. A comparison ideally between a personalized embryo transfer after an endometrial receptivity test and a standard embryo transfer. And we meta-analyzed only those randomized control trials that had low to moderate risk of bias. We didn't want to include high risk of bias. Why including something that we think might be not well or something that in which we can trust, right? And no randomized control trials that were adjusted. Because when you don't have randomized control trials, the best thing that you can do is to obtain the best available evidence, ideally adjusted numbers by the most important variables. Which are those variables that we considered important to be adjusted by and then to include? Okay, we decided to include those that were adjusted by the female age, but number of previously failed embryo transfers, and also by the number and the embryo stage that the embryo transfers were done. And then we compare personalized embryo transfers versus a standard embryo transfer. This is the flow chart. We really searched a lot, more than 2,000 papers, finally including 35 different studies. Okay. And this is what we have. The first thing is that 85% used ERA. So the main thing I have to say here is it will be difficult to say something from the other platforms. Maybe we can find something, but 85% comes from ERA, studies that use ERA. 2 randomized control trials were included, and in both, no history of repetitive implantation failure was there. One of them transferred euploid embryos. And then we also included 25 cohort studies, 21 of them used ERA, but as you can see, population was some heterogeneous, so 7 with repetitive implantation failure, and 3 also, but with PGTA, and then some others in general population, and 4 use other platforms, and then we did some additional tests, evaluations that I will not talk about today because they are not as important so important in this case. And then we found this, 2 randomized control trials. The risk of bias was low in all cases, so we are very happy with this, and that's why the certainty of the evidence of this is moderate. And what we found for live birth rate in this case is that there is, at least with information that we have currently, there is no difference between doing a standard embryo transfer and doing a personalized embryo transfer after ERA. I like to say that it is the current information, what we know today, because it could change tomorrow if we have more information, or if we can do or find a better target or something else that makes not just talk about general, but talk about specific things. Regarding cumulative data, it came from a single, one of the randomized control trials included the cumulative live birth rate and clinical pregnancy rate. But again, in this case, the evidence, the certainty of the evidence is very low. And it's very low for certain issues regarding the number of embryo transfers, that it came from a single trial with less than 400 participants. A few things that that are important to evaluate the evidence, and also to say it's not that there is not a difference, at least I cannot confirm that there is a difference. So maybe we need more information, and with more information we can say something different, but not today. What did we find about the cohorts studies that adjusted by confounding? And there we find something that was a little different. So for live birth rate, ongoing pregnancy rate, we didn't find anything, but for clinical pregnancy rate coming from two studies, remember they were adjusted by all those variables that were important for us. We found with a low certainty of evidence, because it is not a randomized control trial, because it is an observational study, but that was adjusted by important variables, that it favors ERA-based personalized embryo transfer. And this is for patients with repetitive implantation failure. So maybe in the randomized control trials, there were no repetitive implantation failure. In these studies, they are patients with repetitive implantation failures. And I know someone can ask me, okay, what is repetitive implantation failure? We can discuss about that. And I will have a few words at the end. But what I can say by now is there could be a difference between definitions in those studies that were included. Still, in them, they found finally a difference. So it is not too easy to extrapolate, but at the same time, it gives us important information to say and to think, okay, we have to do some more research to understand if this is true, because if this is true, maybe we have a tool here to be used in this population. Sorry, I will see this. So in summary, for women without repetitive implantation failure, the personalized embryo transfer did not prove to be effective for live birth rate and clinical pregnancy rate. For women with repetitive implantation failure, clinical pregnancy rate may be higher when using a personalized embryo transfer after, in this case, ERA. So that is something that we should know. We use the word may whenever the certainty of the evidence is low. And then what we know is that we need more and better quality research to understand, especially in this population, if it is useful or not. We talked about heterogeneity. I just want to make a list of some things that we found: population, intervention, co-interventions, number of transfer embryos, PGTA, different outcomes, different comparisons, and different procedures or variables within each procedure. ERA, other platforms, we have to test each of them. All of them are named endometrial receptivity tests, but they use different set of genes, different technologies, so we cannot assume that they are the same. We have to test each of them, even when they try to evaluate the same thing. And then we have heterogeneity in the population regarding the failures and what it is a repetitive implantation failure. So in summary, well, I will not repeat it, but some things that are important for me is there is no good quality for non-repetitive implantation failure, maybe because we have too high false positives. I don't know if that is the reason, but that could be eventually a reason, probably, or maybe there are some other reasons for that. We have low certainty for the repetitive implantation failure, but we still need more information. And finally, and to finish with this, I want to talk a couple of words about repetitive implantation failure concept. So there are some authors, especially Paul Pertea, among others, that started asking, and it is fair, what is a repetitive implantation failure? Is it just a matter of statistics? Because it is probably not the same. 3 embryo transfers that are negative in a person that is, or in a woman that is 30 years old, or with eggs that are 30 years old, than in a person that is 42, right? So it is fair to understand that numbers could change. And here, Paul asked if 3 successive euploid embryo transfer or more non-tested embryos is the magic number. We don't know really which is the magic number, and he proposed here some numbers to understand. But again, and the same as for the beginning, I don't want to put just a big important title saying something is bad or like that. So here it says, ERA test was heavily marketed well before any proof. I don't like those type of phrases, especially when the explanation behind that is that statistically it shouldn't be like that. It is a good hypothesis. We need to test and prove everything we say. So I would say what we still have is some uncertainties. So let's talk about certainties and uncertainties. And from there, we can start talking about evidence. So, final thoughts. There are many platforms for endometrial receptivity test. Each of them requires its own supporting evidence. Current evidence do not support routine use of these platforms in women without repetitive implantation failure. Repetitive implantation failure is not consistently defined, and then withdrawing conclusions is not that easy, but we should make more research in this specific group, because this specific group could have some benefits according to the current evidence that was evaluated. And then more and better studies are needed to confirm these initial findings. This is all. Thanks.